If you're a plastic surgery resident listening to this right now, we know exactly what you're up against.
Yeah, the board exams.
Right, the FRCS specifically. It's looming on the horizon. You're busy, you're exhausted, and honestly, you absolutely do not have time for fluff.
None at all.
You need high-yield, densely packed clinical information, and you need to be able to recall it under immense pressure. So we're skipping the pleasantries today.
We are jumping straight into this deep dive.
Exactly. Our mission statement for this session is clear. We are going rigorously through the critical pathologies and the complex reconstructions of the penis and the bladder.
And that is the perfect mindset to have for this material. We're running the session as a rapid-fire, targeted question and explanation interview.
But we're also going to dissect the reasoning behind the surgical choices.
Right, because we know you might be listening to this on your morning commute or maybe between cases in the break room.
Or late at night trying to make sense of a massive textbook.
Exactly. Our goal is to maximize your learning and genuinely unpack the concepts so you aren't just memorizing lists.
We're going to hit the exam essentials, the major surgical pitfalls, and those core reconstructive principles you absolutely must know to pass.
Let's unpack this immediately and get to work.
Okay, we're starting with our first major topic today, which is Balanitis Xerotica Obliterans.
BXO.
Right, you will almost always see it abbreviated as BXO in clinical notes. Now, in the world of board exams, examiners love to test your knowledge of alternative nomenclature.
Oh, they love a good trick question.
They really do. They want to know if you can recognize a disease when they use its older or its dermatological name. I used to see BXO referred to in the literature under a different title, which totally confused me until I realized they mapped to the exact same pathology.
Yeah, you have to be careful with that.
So what is that alternative medical name that residents need to look out for?
You need to recognize it instantly as lichen sclerosus epitrophicus.
Lichen sclerosus epitrophicus.
Right. If you're sitting in the exam hall and you see that specific term on the paper, you need to immediately map it directly back to everything we're about to discuss regarding BXO.
Because they are one and the same in this context.
Exactly. It's a classic trap. They use the dermatological term to see if you actually understand the underlying disease process rather than just recognizing the surgical abbreviation.
It's a mouthful, but the name actually gives away a lot of the clinical picture if you just break it down.
It does.
Sclerosis implies scarring and hardening, and epitrophicus points to the thinning and wasting away of the tissue, which brings us perfectly to the clinical presentation.
The visual is key here.
Right. When you are looking at a clinical photograph on an exam slide, or when you are examining a patient in the outpatient clinic, the hallmark visual presentation is incredibly striking.
Very striking. You are looking for a very characteristic, stark white appearance on the affected skin.
That white appearance is your absolute visual anchor for this diagnosis.
Yeah, the tissue completely loses its normal elasticity and color, taking on that pale, almost parchment-like quality.
So when you see that distinct white altered skin on the glands or the prepuce,
BXO or lichen sclerosus epitrophicus should immediately jump to the very top of your differential diagnosis.
but what is critical for the exam is understanding that we are not just dealing with a simple cosmetic issue here.
No, not at all. It's not just a superficial dermatological change.
Right, and here is where the stakes get incredibly high for the patient and where the examiners will absolutely test your clinical judgment. There's a severe implication tied to that white scarred tissue.
BXO is definitively a premalignant lesion.
And you cannot just stop at the word premalignant when you are answering an examiner.
You have to be highly specific.
You have to name the exact type of malignancy you are worried about.
Right. BXO is specifically associated with the development of squamous cell carcinoma.
SCC.
SCC, yes. Specifically in adult patients.
That direct link to squamous cell carcinoma in adults dictates our entire surgical philosophy for this disease.
It really does. But before we get to the surgery, we have to consider the mechanical problems this scarring causes.
Because aside from the terrifying oncological risk, the tissue changes aggressively over time.
Exactly, and it severely compromises the functional patency of the urinary tract. Patients will present with the late development of severe strictures.
What kind of strictures specifically?
You need to know that they develop medial stenosis, where the actual opening of the urethra narrows down.
Right.
Or they develop a neurethral structure further along the tract.
It's just a miserable functional outcome for the patient. They present with obstructed voiding, straining, and all the complications that cascade from a blocked urinary tract.
It's awful.
So you have a patient with medial stenosis or neurethral stricture, and you know the tissue causing it is actively premalignant for SCC.
That naturally dictates a very aggressive strategy.
Yeah.
Exactly. Aggressive surgical and medical management. Because we're dealing with a premalignant lesion, our surgical approach cannot be timid.
Not at all. The foundational surgical treatment for BXO requires radical excision of the affected skin.
You cannot simply shave this down.
No, or try to preserve compromised tissue. The affected skin must be radically excised to manage both the immediate functional strictures and to completely eliminate that long-term oncological risk.
You have to clear the diseased field.
But as reconstructive surgeons, taking the tissue away is only half the battle.
Right.
Once you perform that radical resection, you are left with a significant defect on the penis that desperately needs coverage.
And this brings us to a crucial exam point. Probably one of the highest yield traps a board examiner is going to set for you. You have to choose the right tissue to reconstruct that defect.
And the defect should be reconstructed using mucosal grafts.
Specifically, you have two highly reliable donor sites for this reconstruction.
Right. You harvest these mucosal grafts from either the mouth, so buccal mucosa, or from the bladder.
Buccal mucosa or bladder mucosa.
These are your safe harbors for graft selection. They're safe because of how those specific mucosal tissues behave once transferred.
But examiners don't just want to know what you would do.
No, they want to know what you absolutely must never do.
The massive pitfall.
Yes. The pitfall you must avoid is attempting to use interprepucial skin grafts to reconstruct that defect.
If you use local interprepucial skin, you are walking straight into a disaster.
A complete disaster. Because those specific local grafts are highly prone to developing recurrent BXO.
It makes perfect sense when you think about the disease pathology. If you use the interprepucial skin, you're essentially using tissue from the exact same neighborhood that is already demonstrating a genetic or environmental susceptibility to lichen sclerosis erythrophagus.
Exactly. You are just resetting the clock on the exact same pathology.
And the patient will be back in your operating room with another stricture and renewed cancer risks.
So avoid interprepucial skin at all costs. Stick definitively to the mouth or bladder mucosa.
That covers the surgical excision and grafting. But we also need to touch on the medical management side of things.
Right, the topicals.
In certain cases, you might consider topical treatments, like steroids or tacrolimus, to manage the inflammatory component of the disease.
However, there is a major clinical caveat here when BXO presents in the specific context of hypospadias.
Right, topicals may not be appropriate in those cases.
And you need to understand the anatomical reason why.
It comes down to the depth and anatomical extent of the disease. In a patient with hypospadias, the disease process is very rarely just superficial.
Exactly. The urethra itself, and not merely the external glands, is highly likely to be involved in the BXO pathology.
So if you're just applying a topical steroid or tacrolimus cream to the external glands,
You're completely failing to treat the involved urethral tissue deeper inside.
you're treating the tip of the iceberg while the stricture continues to worsen out of sight.
It is a perfect example of why you have to treat the entire anatomical extent of the disease, not just the visible surface.
That perfectly wraps up our deep dive into the BXO pathology, its oncological risks, and its strict reconstructive rules.
Let's pivot now.
Yes, let's move to our second major high-yield topic for this revision session, the bladder exstrophy epispadius complex.
This is a massive, multi-system congenital anomaly.
It really is.
Yes.
And we need to start right at the foundational background. Let's start with the etymology, because the word itself paints a picture of the clinical presentation.
It does. The term exstrophy is derived from Greek,
And it translates directly to meaning to turn inside out.
which is exactly what we are visually confronted with in the delivery room when one of these infants is born.
The internal mucosal surface of the bladder is completely exposed to the outside world.
But to understand how to fix it, we have to understand why it happened in the first place.
When things go wrong embryologically, the primary failure is thought to be due to the failure of mesenchymal penetration.
That phrase, failure of mesenchymal penetration, is the core embryological deficit you need to cite for the exam.
How should they visualize that?
To visualize what that actually means, imagine the developing fetus. The mesenchyme is the embryonic connective tissue that needs to actively migrate and penetrate toward the midline of the lower abdominal wall.
To form the structural layers.
Right, the muscles, the bones, the connective tissue. When that mesenchyme fails to penetrate and meet in the middle, the structural integrity of the entire anterior lower half of the body is completely compromised.
And because that mesenchyme fails to reinforce the midline, The cloacal membrane eventually ruptures prematurely, leaving everything wide open.
It leads to a complex of abnormal development across multiple systems.
You need to be able to systematically list the 4 specific anatomical areas that suffer abnormal development in this condition.
Starting from the outside and moving in,
We see abnormal development of the dorsal surface of the penis,
followed by the abdominal wall,
then the deeper pelvic bones.
and finally the anterior wall of the bladder itself.
It is a devastating, multi-layered defect. Dorsal penis, abdominal wall, pelvic bones, and anterior bladder wall.
When you are asked about the epidemiology of this complex, you need to know the most common presentation you'll encounter within this spectrum.
Right. The most common deformity by far is bladder exstrophy, combined with complete epispadius.
In terms of the raw statistics, this specific combination of bladder exstrophy and complete epispadias occurs roughly once in every 30,000 births.
1 in 30,000. And it carries a very strong gender predilection.
Yes, you will see this condition 3 to 4 times more commonly in male infants than in female infants.
So 1 in 30,000 births, predominantly male.
Let's move from the statistics into the actual diagnosis and the surgical correction of this massive complex.
We'll break the reconstruction down anatomically, starting with the epispadias component.
The clinical features of epispadias can vary from mild to major, but there are defining clinical features you must recognize.
And crucially, they present very differently depending on the sex of the patient.
Right. In the male patient, epispadias is fundamentally characterized by a urethra that opens abnormally onto the dorsal or top surface of the penis,
Rather than at the tip. That is the classic defining feature.
However, in the female patient, the anatomy shifts entirely due to that midline failure.
You will see a completely cleft clitoris, and the labia will be widely divergent.
Splayed apart because the underlying structures never fused.
When it comes time to surgically correct the epispadius, regardless of the severity, the overarching principles of the repair should feel familiar to you.
Epispadias is repaired using very similar surgical techniques to those you would use for a hypospadias repair.
So the fundamental reconstructive principles of carefully modalizing the local tissue, creating watertight closures, and meticulously reconstructing the urethral tube.
They remain incredibly consistent across both of those conditions.
Now let's unpack the rest of those massive anatomical defects we listed earlier. We talked about failure of the abdominal wall and pelvic bones.
Right, because that mesenchyme failed to cross the midline, these patients present with immense structural separation.
Muscularly, you will see a profound diastasis of the rectus abdominis.
The abdominal muscles are completely split apart.
And skeletally, beneath those muscles, there is a severe diastasis of the pubic rami.
That diastasis of the pubic rami means the pelvic bones are splayed wide open, resulting in an open pelvic ring.
This isn't just a cosmetic issue.
Not at all. It is a fundamental loss of structural and orthopedic stability for the entire lower body.
You cannot just pull the soft tissues together over an open bony pelvis and expect it to hold.
The tension would be catastrophic.
So how do we definitively correct that open pelvic ring?
This requires stepping slightly outside pure soft tissue plastic surgery and incorporating heavy orthopedic principles.
The open pelvis is definitively closed using osteotomies.
You literally have to surgically cut the pelvic bones, mobilize them, and physically reposition the skeletal structure to close that ring.
To provide a stable, solid foundation for the rest of the soft tissue reconstruction.
The osteotomies are the absolute anchor of the entire repair. Without closing the bony ring, everything else you do will fail under tension.
Finally, once the epispadias is addressed and the pelvis is stabilized, we have to tackle the bladder itself.
Pathologically, because of that midline failure, the anterior wall of the bladder may be entirely absent.
And because that anterior wall is missing, the posterior wall of the bladder pushes forward and exposes itself to the outside world.
This is where bladder inversion occurs.
Tying right back to our Greek definition at the start of the deep dive, the bladder is quite literally turned inside out and exposed on the abdominal wall.
So how does a reconstructive surgeon actually fix an everted bladder that is missing its entire front wall?
The surgical reconstruction of the bladder is a highly deliberate spatial process.
First, you must meticulously dissect the exposed bladder plate entirely off the anterior abdominal wall.
You have to free it up completely from its abnormal attachments.
Once that bladder plate is fully mobilized and pliable, you take the lateral edges of this plate and you fold them inward,
Suturing them directly to each other.
It is incredible to visualize. You're taking a flat, everted plate of tissue, peeling it off the abdomen and rolling its edges together.
And by suturing those lateral edges to each other, you successfully recreate the three-dimensional bladder cavity out of the existing tissue.
It is a phenomenal feat of spatial reasoning and tissue mobilization.
It really is. We have covered a tremendous amount of highly technical ground today, moving from the aggressive oncology of BXO all the way to the multi-system embryological failures of exstrophy.
As we wrap up this revision deep dive, I want to leave you with a final provocative thought to mull over before your exams.
Think about the stark, fundamental contrast in tissue management between these two conditions we just analyzed.
It really highlights the diverse problem-solving required in our field.
On one hand, you have BXO. This pathology demands an entirely ablative mindset. It requires the radical, uncompromising excision of compromised, potentially malignant tissue.
It forces you into meticulous, highly specific graft selection, relying on oral or bladder mucosa.
While actively forcing you to avoid local preputial tissue that harbors the exact same disease risk.
It is a mindset of removal and cautious, selective replacement.
But then, contrast that completely with the exstrophy Epispadius complex.
In exstrophy, you are not excising a diseased or malignant tissue.
You are taking existing, albeit profoundly abnormally developed, tissues and completely rearranging them in three-dimensional space.
You are closing an open pelvic ring by breaking bones with osteotomies, and you are mobilizing an inverted, flat bladder plate just to recreate a functional cavity.
It's a pure mechanical correction of a foundational mesenchymal failure. You are taking what is there and forcing it to become what it was supposed to be.
Recognizing how entirely different these two problem-solving approaches are.
Knowing exactly when to radically excise and knowing exactly when to meticulously mobilize.
Is what separates a competent resident from a master reconstructive surgeon.
You have to be able to switch between those mindsets seamlessly, both on a written exam paper and under the bright lights of the operating room.
Absolutely. The exam tests your knowledge, but it is also testing your surgical philosophy.
If you want to make sure you catch more of these high-yield revision deep dives, press follow on the show right now so you don't miss the next session.
And if you actually learned something useful for your FRCS board prep today, take a second to rate the show. It tells us we're hitting the mark and helps us keep delivering exactly the dense, high-yield material you need to pass.
Also, if you want to take your preparation to the absolute next level and guarantee you are ready for anything the examiners throw at you, you need to get a premium subscription right now.
That is where you will get exclusive access to listen to our journal club and our in-depth clinical cases deep dives. You really do not want to walk into your boards without having heard them.
Finally, we want to hear directly from you. Leave a comment or a question about the material we rigorously discussed today. Did the specific choice of buccal mucosa over interpreputial skin surprise you?
Or do you have a lingering question about the mechanics of the pelvic osteotomies or the embryology of mesenchymal penetration? Let us know down below.
Keep studying hard, keep reviewing the high-yield facts, and we will see you on the next deep dive.